Hello to anyone listening. This is an instructional video on when, why, and how to perform laparoscopy in patients diagnosed with Kohlmeier-Degos disease.
To begin, I would like to say a bit about what Kohlmeier-Degos disease is. This is an ultra-rare obliterative vasculopathy that presents in two forms. One is a benign cutaneous form, meaning it is restricted to the skin and presents with skin lesions, and the other is a potentially malignant systemic form, in which virtually any organ system can be involved. About 30% of the cutaneous Kohlmeier-Degos develops into systemic Kohlmeier-Degos, and the most common involvements include gastrointestinal and central nervous system disease. Other common involvements can include pleural, pericardial, and ophthalmic disease. It is important to note that without treatment, most patients with the systemic form will succumb to the disease within a few years, and the most common cause of death is often bowel perforation that leads to sepsis.
Here we will review the necessity for directed laparoscopy. Bowel perforation is often, though not always, preceded by at least one gastrointestinal symptom, which can include abdominal pain or cramping, weight loss, vomiting, diarrhea, nausea, bleeding, and others that are new or unusual symptoms for your patient. We have found laparoscopy to be the most sensitive and specific diagnostic technique for detecting Kohlmeier-Degos disease bowel lesions, as it is the serosa of the bowel that demonstrates porcelain plaques similar to those on the skin and characteristic for KD. It is important to perform laparoscopy as this allows the observer to visualize the serosa, whereas colonoscopy or endoscopy will only show the mucosa, which may not have lesions. There is the potential for false negative laparoscopy due to failure to recognize what these bowel lesions look like. This can lead to a missed Kohlmeier-Degos disease diagnosis, and therefore a missed window to initiate eculizumab, which has an immediate onset of action and can prevent bowel perforation. This will be discussed more on the next slide. But here we can see what these bowel lesions look like on the serosa. I'm highlighting certain areas that show these porcelain plaques on the serosa. As you can see, they may be white or yellow in appearance, and they resemble those lesions on the skin. There are some differences in bowel lesions versus skin lesions in that the skin is more commonly surrounded by a rim of telangiectasia, where on the bowel that might not be apparent. Here we will outline when to conduct laparoscopy in KD. Laparoscopy should be conducted promptly in a patient diagnosed with cutaneous KD who experiences new or unusual abdominal symptoms as outlined on the previous slide. It should also be performed in any patient with evidence of systemic KD in another organ system, such as the central nervous system, with evidence of pleural or pericardial disease, ophthalmic disease, etc. Bowel lesions can be present in the absence of abdominal symptoms, as alluded to on the previous slide, and we have seen one unpublished case of this. Therefore, some experts would advise laparoscopy in any patient who has biopsy-confirmed cutaneous KD. Repeating the laparoscopy every few years based on other symptomology may also be reasonable. If lesions consistent with KD are identified on the bowel serosa, treatment with eculizumab should be initiated very promptly. This is because eculizumab has immediate onset of action and needs to be initiated before perforation occurs, as it can prevent perforation and therefore ensuing sepsis and potentially death. If treatment is initiated after perforation has occurred, outcomes are less predictable. Addition of treprostinil is necessary to maintain long-term remission from gastrointestinal KD. But again, to emphasize, the treatment with eculizumab in the moment is of most importance, and therefore laparoscopy is necessary promptly so that you have sensitivity and specificity of detecting the lesions that will allow for the initiation of eculizumab, which is a potentially life-saving medication. Here we will go through several images that demonstrate what KD lesions look like on the skin and the bowel. To start, in the top left corner, you can see what the classic cutaneous KD lesions appear as. Note that there is the central porcelain region surrounded by a rim of erythema. Lesions can be distinct or confluent. Dermoscopy will reveal a magnified image that shows the central atrophic avascular region surrounded by a rim of telangiectasia. These lesions are quite distinct with a limited differential, and if you see them, biopsy is warranted. The bowel lesions, as demonstrated in images B, C, and D, resemble those on the skin. Here you can see that the bowel serosa may be studded with porcelain, white, or yellow plaques. Note that the size of the bowel lesions may be different than those on the skin. Those on the bowel may be larger and more numerous. The rim of telangiectasia that is more consistently seen on the skin may be absent on those lesions on the bowel. However, in some instances, it can be seen, as here. The bowel lesions are also quite unique in appearance, offering a very limited differential diagnosis, which, according to Dr. Andrew Blakely, may only include peritoneal mesothelioma. Here we will watch a video of a recorded laparoscopy in a patient who has gastrointestinal KD to best demonstrate what these serosal lesions may look like. As you can see here, we have the classic serosal plaques that we were describing on previous slides. They can be present on the serosa or the peritoneum. A biopsy is being taken here. Here you can see the bowel serosa that is studded with several of these porcelain plaques. Present here, 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 some here as well. It may be difficult to figure out what is a plaque and what is glare, and therefore getting a proper visualization of these lesions and using different lights that may better highlight what these plaques look like is necessary. Here again, we can see the serosa with various plaques scattering it. This view shows the liver, and as can be seen here, there is a plaque present. It is therefore important to visualize the liver and capsule and evaluate for any lesions there as well.